Okay, let's just dive right into this. Welcome to the Explainer. If you're gearing up for your CST exam, well, you probably already know that surgical pharmacology is this massive, heavily tested beast. But hey, do not worry, because this Explainer is going to be your absolute ultimate survival guide. We're skipping the fluff, we're crashing straight through the absolute highest yield pharmacology topics, so you are 100% ready for test day, and honestly, more importantly, for day one in the operating room. So here's our battle plan for today. First up, sterile field drug safety. Number 2, local anesthetics and epinephrine. Third, hemostatic agents and anticoagulants. Fourth, the ultimate emergency, malignant hyperthermia. And finally, reversal agents and antidotes. Let's get to work.
All right, Section 1, Sterile Field Drug Safety, the non-negotiable rules.
Listen to this. All medications on the sterile field must be labeled immediately. Now, that isn't just some nice-to-have suggestion. It's a strict, non-negotiable mandate from the Joint Commission. You see, before we can even think about memorizing specific drugs, we absolutely have to master these foundational safety rules. Medication errors are literally one of the leading causes of sentinel events in the OR. Because of that real-world life or death risk, yeah, you can guarantee this concept is going to be heavily tested. So every single time you receive a medication, your label has to include a few things: the drug name, the strength or concentration, and crucially, whether or not epinephrine has been added. You've got to verbally verify all of this with your circulator as you receive it onto your sterile field. And guys, here is the golden rule of surgical tech practice. Never, ever place a drug in a surgeon's hand without verbal confirmation. No way. If you ever find an unlabeled syringe just sitting on your back table, you discard it immediately. Absolutely no exceptions.
Moving on to Section 2, local anesthetics and epinephrine, the most common OR drugs. Okay, I've got a really simple, high-yield memory hack here that is definitely going to save you points on the test. Local anesthetics are split into two groups, amides and esters. Now, amides, which are metabolized in the liver, have two I's in their generic name. Just think about the spelling: lidocaine, bupivacaine, two I's. Esters, on the flip side, are metabolized in the plasma, and they carry a much higher allergy risk. They only have one I, think cocaine or tetracaine. If you just remember that two I's rule, boom, you'll instantly know the difference between these two major classes. Let's contrast the locals you're going to see tested the most. First up, bupivacaine. It has a slow onset, sure, but it gives you the longest duration. We're talking sometimes up to 8 hours. But watch out, it's highly cardiotoxic if there's an overdose. Then we've got lidocaine, the absolute undisputed workhorse of the OR. Rapid onset, lasts about 1 to 2 hours, and it's just incredibly versatile. And finally, cocaine. Now this is for topical use only, specifically in ENT surgeries. It's heavily tested for two big reasons. One, it's a Schedule II controlled substance, and two, it is the only local anesthetic that acts as a natural vasoconstrictor. Now, I need you to pay very close attention here because this is a massive patient safety warning. You must never inject epinephrine into ring structures. We're talking fingers, toes, the nose, the penis, and the ears. Why? Well, these areas rely on an end arterial blood supply. If you inject a powerful vasoconstrictor like epi into them, it literally cuts off the blood flow completely, causing severe ischemia and tissue necrosis. And this right here is exactly why you always have to verify if your local has epi or is just plain.
All right, Section 3, hemostatic agents and anticoagulants, controlling the bleeding.
So let's talk about the absorbable hemostats you'll be prepping to control that dynamic field bleeding. Let's break them down real quick. Gel foam is super versatile. You can use it dry or soak it in thrombin or saline. Bone wax gives you mechanical tamponade, and it's non-absorbable, so you literally just press it right into bleeding bone edges. Avatine is tricky. It must be handled with strictly dry instruments. If you don't, it clumps instantly to your gloves and basically becomes useless. And then there's Surgicel. This is crucial. You must apply Surgicel dry only. Whatever you do, do not wet it with saline. Wetting Surgicel actually inactivates its bactericidal and hemostatic properties. They love using this as a trick question on the exam, so do not fall for it. Speaking of hemostats, we really have to talk about an absolute never event. Topical thrombin, do not inject. Thrombin bypasses the normal coagulation cascade and directly converts fibrinogen to fibrin. So if it gets inadvertently injected intravenously, it causes fatal, widespread intravascular clotting. The patient will die. It's that serious. Because of this, it must always be labeled super clearly on your sterile field as topical use only. Okay, Section 4, Emergency, Malignant Hyperthermia, the ultimate OR boss fight. Malignant hyperthermia, or MH for short, is a severe hypermetabolic crisis of the skeletal muscle. It is triggered by halogenated volatile anesthetics like sevoflurane or the depolarizing muscle relaxant succinylcholine. These triggers cause an uncontrollable release of calcium right inside the muscle cells. Now, the name literally says hyperthermia, right? But do not be fooled by that. The very first sign is almost never a spike in temperature. Actually, the absolute earliest sign is an unexplained rise in end-tidal CO2 that the anesthesia provider simply cannot fix just by increasing ventilation. When MH strikes, the entire surgical team has to act instantly, and I mean instantly, using the exact sequential steps of the MHA's protocol. First, call for help immediately. Somebody needs to dial 1-800-MH-HYPER. Second, the anesthesia provider must discontinue all triggering agents right that second. Third, switch to 100% oxygen and non-triggering anesthesia. Just remember, safe drugs for an MH patient include propofol and non-depolarizing NMBAs, like rocuronium. And fourth, you prep to administer the absolute life-saving antidote, dantrolene. Okay, you need to lock this exact numerical value into your memory right now, 2.5. The required initial dose for dantrolene is 2.5 milligrams per kilogram given as a rapid IV bolus. You are absolutely going to see this number on the exam, for sure, so just burn it into your brain right now. And here's another super crucial number to highlight and memorize: 36. That is the absolute minimum number of dantrolene vials that must be stocked on your facility's MH cart. Reconstituting this drug with sterile water, it takes a lot of hands and a lot of time because it is notoriously difficult to mix. So knowing what the cart is fully stocked and ready to go with at least 36 vials is an absolutely critical safety standard for any OR. All right, final stretch. Section 5, Reversal Agents and Antidotes, the rapid fire finale. Okay, take a breath. This is our rapid-fire cheat sheet of antidotes to test your matching knowledge, and matching is heavily featured on the CST. The crucial point here is matching the trigger to the fix. Let's run through these combos real quick. If your patient has respiratory depression from opioids, the reversal is naloxone. You probably know it as Narcan. But beware the re-narcotization risk, because Narcan actually wears off faster than the opioid does. If the trigger is benzodiazepines, the fix is flumazenol, and for those non-depolarizing NMBAs causing paralysis, you reverse them with either neostigmine combined with glycopyrrolate or the newer encapsulating agent Sugammadex.
Next up, let's map out the blood thinner reversals. You absolutely must be able to clearly differentiate these two. The antidote for heparin is protamine sulfate, but the antidote for warfarin, or Coumadin, is vitamin K for a slow reversal or fresh frozen plasma for an immediate fix. Don't mix those two up. And hey, if they throw a direct thrombin inhibitor like dabigatran at you on the test, just remember the specific reversal agent is edarucizumab.
All right, you know the drugs, you know the triggers, and you know the reversals. But memorizing these facts isn't just about passing a test, right? It's what empowers you to catch fatal errors before they happen. So, when that unlabeled syringe inevitably appears on your sterile field, will you be ready to speak up?